Dr. Tim Jones. I am a certified registered nurse anesthetist. I practice at a critical access hospital in the Texas Panhandle. I am also a fellow at the Advanced Pain Management Fellowship with Texas Christian University. Today I'm going to be presenting a case scenario regarding patient BR. She is here for a follow-up appointment with complaint of severe back pain, causing her to increasingly miss work. The pain is withstanding and described as midline low back pain with radiation to bilateral feet approximating the S1 dermatome. Her past medical history addresses asthma with frequent pneumonia, sarcoidosis with no known focal point, past alcohol abuse, cervical spinal stenosis, chronic low back pain with acute exacerbation, and sacroiliitis. Past surgical history indicates an L4-L5 laminectomy, which occurred in 2004, with resolution of right lower extremity radiculopathy, and also an L5-S1 laminectomy in 2014, which also resulted in good relief of back pain and left lower extremity radiculopathy. Hard films from 2016 showed mild levoscoliosis, a grade 1 anteriolisthesis at L4-L5. Also, L4-L5 has loss of disc height, facet arthropathy, and degenerative disc disease. At L5-S1 shows bilateral foraminal narrowing with flexion. The lumbar MRI from January of 2016 also indicates L4-L5 and L5-S1 post-surgical changes as stated. There is peridural fibrosis noted at L4-L5 and spinal stenosis. There's also synovial cyst noted bilaterally at L5-S1. As mentioned previously, Miss BR is here for a follow-up visit with complaint of severe back pain, with standing described as midline lumbar and bilateral radiculopathy approximating the S1 dermatome. Medications are as listed. Of note is possible long-term opioid use and prescription of Lyrica and gabapentin together. Patient may be seeing multiple providers. Prescription needs to be clarified, reconciliation with the patient and/or patient history. General appearance is as listed. There are no indications the patient is out of norm regarding body habitus or any outlying psychosocial issues. Okay, this is Miss BR. We're going to do a quick test. What I want you to do is lean backwards. Now I want you to lean towards your left, and I want you to rotate back. I want you to hold that for just a couple of seconds. Perfect. Now once again, I want you to lean backwards. I want you to lean towards your right, and I want you to rotate backwards, and hold that for just a few seconds. Okay, that's very good. Okay, we're going to do a straight leg raise. What I'm going to do is put my hand on your knee, and I'm going to raise your leg straight up, and let me know if you feel pain. Okay. We're going to do that to your left leg. Perfect. What I'm going to do now is ask you to bend your knee, and we're going to cross your foot onto your left. Up there we go. Now I'm going to press down on your leg and let me know if there's pain. Okay. We're going to do the same thing on the left. Perfect. We're going to press down. Okay, what I want you to do is turn over onto your left side. Knees bent. Perfect. I'm going to press down on your hip here. Once again, let me know if you experience pain. Okay. All right, at this point, if I can ask you to sit up with your legs crossed.
You don't want to do that.
No, that's fine. That's perfect. What I'm going to do is feel on your back. Okay, now I'm going to palpate on both sides. And I understand that you have some pain here. Okay. And pause. Okay. What I want you to do is raise up against my hand. Nope, your knee. Raise your knee. Now I'm going to press down. Resist me. Okay. Raise your knee. Resist me. Okay. What I want you to do is kick me. Pull in. I want you to kick me. Pull in. I want you to press on the gas. I want you to pull up. I want you to press on the gas. I want you to pull your foot up. Perfect. Now that it flexes. Here. Tell me if there's any place here that feels less than the other.
Feels all the way across.
And I'm going to do the same here.
Felt all the way across.
Okay. Tell me what this feels like.
It's a cool sensation.
And is it different anywhere?
Nope.
Okay.
It's the same.
And then I ask you to stand up. I want you to walk on your tiptoes towards the camera. Now turn around and walk on your heels back towards me. Okay, thank you, Mrs. BR. Okay, the physical examination displayed that she had facet loading or Kemp's test was positive bilaterally. On extension, she was positive at 10 degrees. With flexion, she was positive at 30 degrees. With lateral flexion, she was positive bilaterally at 20 degrees. With rotation, she was positive bilaterally. Right was 20 degrees, left was 30 degrees. She did experience vertebral tenderness with inspection and palpation at approximately L4-L5. Straight leg raise was negative bilaterally. Her SI joints were positive bilaterally, specifically with the Patrick's test, which was positive bilaterally. Also, the lateral SI joint compression was negative bilaterally. Neurological examinations indicated that to light touch was absent on the left S1 to pinprick. It was diminished left at 3, 4, 5, and S1. Neurological examinations regarding reflexes. The patellar was 1+ bilaterally, and the Achilles was absent bilaterally. The treatment plan, this is a multifaceted pain patient with potential for facet joint pain, failed back surgery syndrome with S1 radiculopathy, SI joint pain, and cervical pathology. The plan is for a medial branch nerve block with local anesthetic only as a diagnostic test at L3, 4, 5 bilaterally. My plan is to use local anesthetic only without steroid due to unknown use, dose, and duration of prednisone. Plan will be to consult with the primary care provider regarding prednisone prescription. Follow-up will then be in approximately 2 weeks for a second medial branch nerve block injection. If 2 successful injections, we'll consider radiofrequency ablation. Continuation of Plan A would be to decrease opioid daily consumption by consulting with the primary care provider. Also, discontinuation of either Lyrica or gabapentin. Once again, we'll consult with the PCP. Discuss a long-term prednisone prescription with ordering provider and evaluation by a pulmonologist for asthma with frequent pneumonia and sarcoidosis with possible lung involvement. Plan will also be to refer to physical therapy. BR has a new onset of axial low back pain with radiculopathy, SI joint pain, and cervical stenosis. Referral to the PCP also because of left edematous olecranon bursa without drainage. Treatment Plan B would be related to her failed back surgical syndrome. At L4, L5 in 2004 and L5S1 in 2014, laminectomies. She does have radiculopathy bilateral at S1 dermatome. Noted also on the MRI was an L4-L5 facet arthropathy, peridural fibrosis, spinal stenosis, and at L5-S1 synovial cyst bilaterally. At that point, we would consider caudal epidural steroid injection. Treatment Plan C for this patient could potentially be a sacroiliac joint steroid injection. Goals are to decrease axial low back pain by greater than 50%, post-diagnostic medial branch nerve block injection without steroid. Also decrease opioid requirement, increase activities of daily living with decrease in pain, and active PT participation. Thank you very much. Thank you so much. Now let's hope I can upload this to YouTube.
Oh, yeah.
That's my biggest concern.
Well, we have a computer guy at our house.
Oh, that's true.
He's actually not at the house, but
Okay.
he probably is.
Well, I just heard that Jason's a guru and things like that, so that's good.
There you go.
Now let's just make sure I don't delete this.
Yeah, don't delete